platform without any commercial bias, and it was going on with a lot many trainings, laparoscopic training and endo training, teaching sessions, live workshops, and helping residents and surgeons from across the country and many from SAARC countries and neighboring countries as well. People are requesting to get join in. So it was all going on fine with every faculties and everybody getting involved into all this and everybody enjoying the teaching and training sessions. It was all going on when I switched over to AIIMS Bhubaneswar, and the same passion continued there also. So we started the Advanced Laparoscopic Surgery Training Center in AIIMS Bhubaneswar, and we started the first postdoctoral fellowship course in minimal access surgery. That's the first time in eastern part of the country. And then the COVID set in. This academic forum and platform got more activated. So initially I started all my own weekly event I was holding. Then I chipped in with all colleagues from across the country and around the world. And happily and luckily, all my friends and colleagues across the world, they obliged to me and accepted my request to join in and chip in. So all the friendship that we had before could be encased onto this knowledge sharing platform. Now this is growing on as a big, which started as a local platform, now is an international platform with around more than 800 members in the Facebook page, which has the name on the AIIMS Bhubaneswar on the top, but SCB Medical College Advanced Laparoscopy still is continuing on the Facebook page. So 800 members have already joined in this group. So today we have a distinguished speaker, Prof.Robert Rutledge from Southern California in US. And Dr. Rutledge, in fact, has got many accomplishments in his career. If I went through his CV, it was it's a volume of book, but I'll just pick up much fewer that I could deliver here. So he is a man who is dynamic right from the beginning in the both academic as well as in the surgical field. His academic accomplishments started in Department of Surgery in University of North Carolina in 1986. Was an assistant professor there. Then he became an associate professor from 92 to 97 in the same university. Then he went on to become a professor there in 98 till 98. Then he became a director there also. And from 98, I think he thought that it's enough of enough. He switched over to private practice and he is continuing there till that. These are all the academic accomplishments, and he has got several significant accomplishments. And one of the main things for which Dr. Rutledge is known worldwide and people know him is for his 1997 following the care of a trauma patient that required urgent exploration for multiple gunshot wounds. Dr. Rutledge applied his skills and expertise in general and trauma surgery to bariatric surgery, using the standard surgical procedure of aneuploidy and Billroth 2 in creating the mini gastric bypass. In fact, this mini gastric bypass is a big game changer in bariatric surgery. So from 97 to 2015, he has performed more than 6,000 cases and he has published more than 100 articles. He is having a MGB corporation now. So Dr. Rutledge himself is an institution by himself. So it's a safe, successful procedure. He has proved worldwide, and it is probably taken up much wider acceptance worldwide, this MGB, than any other bariatric procedure. So some of his lifetime achievements are, he was the first man in 1997 who adapted the new laparoscopic technique for Roux-en-Y gastric bypass. Then he created the mini gastric bypass, and he has performed more than 6,000 MGBs, many awards and accolades for him. Just one of the most important among all of them was a healthgrade.com award. And he is a worldwide international visiting professor in many countries, from UK, France, Italy, Germany, Czech Republic, Spain, Turkey, India. So many countries he is a visiting professor. He is a national and international lectures, and he is an invited professorship in many, many other countries also. So he's an accomplished teacher, he's an accomplished surgeon, and a fantastic human being. I mean, I can vouch that Dr. Rutledge talks and behaves with me for last, that we got introduced to each other in such a friendly way that I sometimes feel as if I know him for quite many years. So thank you very much, Dr. Rutledge, for accepting my request and joining us and sharing your knowledge and wisdom on mini gastric bypass. And to moderate this session, we have a very young, talented surgeon whom I, in fact, call as brother. So he's Dr. Kuldeepak Singh Kular. He's the director of Kular Hospitals Private Limited in Ludhiana in Punjab. And this man has got tremendous experience in this bariatric surgery, and he's a close associate of Dr. Rutledge. So he also has performed many bariatric procedures. He is the founder president of the Mini Gastric Bypass World Association of Bariatric Surgeons, the MGB OAGB International Surgeons Club, has performed more than 6,500 weight loss surgeries in his career. So thank you, Dr. Kular, for accepting my request to be moderating this. So it's a pleasure to have both of you today evening. So in the next week, in the same time, we'll be having my teacher, my mentor, Professor Palni Velu. Sir will be there on the minimal invasive approach in Whipple's operation. In fact, we have had many sessions on Whipple's. All of them were on open Whipple's operation. So I think we must know that how the world is moving ahead in minimal invasive way, whether be it laparoscopic Whipple's or robotic Whipple's. In fact, we are also started doing our laparoscopic front. So next week, same time, Palni Velu sir will be with me. And all of you are all welcome to join next week, same time, this minimal invasive Whipple's operation, the way forward. So thank you very much. Without wasting much time, I hand over the screen and air to Dr. Kular. So Dr. Kular, it's all yours.
Thank you, Dr. Manash. Thank you very much. It's a nice evening and very good evening to all the members who are online. And I can see we have about 70 members already there online. And I can see my friend, Dr. Hagroder, Dr. Carl Renwald. How are you, brothers? Nice to see you. About Dr. I think without wasting time, we should tell Dr. Rutledge to start. And I want to just add 2 or 3 more lines to his introduction. Basically, Dr. Rutledge has been controversial from day one.
Okay.
It's not only because of the mini gastric bypass. Those who know him closely, he has been controversial because he started using the email for the first time in US as a surgeon, bariatric surgeon, as a trauma surgeon. And he was the first to start using a website.
Okay.
Then to start using YouTube. So he has been a lot controversial. And about his achievements, this is not only about the mini gastric bypass. As a trauma surgeon, he was instrumental in setting the standards for handling the shattered spleen conservatively, which was a big controversy in those times. You know, nobody would look at this thing to, you know, even raise a question about handling a shattered spleen conservatively. And now we all know that it's a matter of general surgical principles. Now we follow this. So Dr. Rutledge, when I met him for the first time at his center in Nevada, before that I got trained in Houston, Texas, and we were kind of used to doing this Roux-en-Y gastric bypass. And I was of the opinion that bariatric surgery is all about Roux-en-Y gastric bypass, and it takes about 2 hours to perform the procedure, and patient has to have some pain and has to be in the ICU, has to have, you know, some tubing coming out, some drains from here or there. But when I met him, I saw his first operation. That was about more than 15 years back, I suppose. And Dr. Rutledge performed it in 19 minutes. And another controversy, you know, to his part, his anesthetist actually did that under TIVA. I could see that white, you know, fluid going down into the patient's IV line. There was propofol and in combination with, you know, a few other drugs, 4 or 5 drugs. And he has been the first surgeon in US to start doing bariatric surgery under TIVA. And the patient was sitting in the bed and walking within 1 hour of the surgery. So I was kind of quite amazed to see all this and got impressed. And then there was no look back, and I got a chance to start this in India. So Dr. Rutledge, over to you. So please introduce all of us to your mini gastric bypass, the procedure, and whatever you want to say about mini gastric bypass.
So Dr. Rutledge, I conclude that if you become controversial, then you become successful from Dr. Kular's version.
Probably we are going to start another controversy now, because
Okay.
mini gastric bypass is now kind of standardized. And now he is going to, start up another controversy. You will see that in very near future.
Absolutely, absolutely.
Yes, another way to say your kind words is that I've caused a lot of trouble, and I hope not to cause too much trouble tonight, but you have all been much too kind to me. Dr. Kular, Dr. Manash, I am humbled by your kind words. And I will just go forward, recognizing so many of friends already in the pictures. Dr. Hargroder, I'll tell one story about him. When I was honored to train with him, after a few months, he said, "That's enough, please go away and stop coming to visit." And so we had a big party, and we had some food, and we all got cowboy hats, big white cowboy hats. And we announced that there was a new sheriff in town. Dr. Hargroder then took over, and since that time has been doing spectacular work along with Dr. Kular, and they've taken leadership and actually changed the world. And so they and Dr. Paragli, Dr. Reinwelt, and others took tremendous criticism, and now we're seeing, I think, the benefits of those changes. And I hope that I can show them a few new little things that maybe they don't know about, little tricks and traps that I've found that maybe even their very skilled knowledge background could be slightly helpful. So I'll go ahead and start. My plan is, if you all agree, is I'll give a little introduction, a couple of pictures and things like that, and then I'll let some questions come through and Dr. Kular give me advice, because I have a variety of topics that I'm happy to talk about tonight. There's some very new and exciting research. There's some basic tips for the surgeons who are thinking about or just beginning their path, as well as some real advanced things, and then some big plans that we have coming up with our colleagues in Mexico, in Tijuana. Dr. Ilan and his team, I can see Stacy and Bill, say hello to them, Dr. Kular, and so we're all excited about this, and I'll say no more, but go ahead and begin my presentation.
So before Dr. Rutledge start, could I request everybody to keep mic muted, and please do not click the present now button. You can click the present now and then click the entire screen and share. That's it.
I'm trying.
Yeah, great.
Oh, there it came. Good. Oh. Okay, when I try to go to, got it. Send now, window. Okay, I'm going to talk a little bit about the MGB Review Corporation and a bronze certificate course, with the idea of basically better care and fewer complications, and correcting some of the confusing and misunderstanding of the mini gastric bypass, and try and point out that the ideas behind the mini gastric bypass are not new or different, but there's just general surgery, just basic general surgery. I'm kind of proud of this. This is my travels in the past 10 years. And you'll see that throughout Europe, the Middle East, Arabia, India, and I'm happy to say also Pakistan have been on my routes, and I've been blessed to visit many of those countries and be invited to teach about the mini gastric bypass. Of course, I need to thank my brothers here in Punjab, Dr. Kular and Dr. Magenda, and my friends in the bronze course we had in Australia, my friend in Pakistan, Portugal, Turkey, Birmingham, England, Spain, Kazakhstan, the Azores in the middle of the Atlantic Ocean, Italy, and numerous other countries. And before I begin, let me say I'm trying to be humble in saying all of us commit ourselves to the care of our patients, our families, and our country's health. And I would like to offer that anyone can contact me, call me anytime, either by email or WhatsApp or Facebook Messenger. I'd like to try and help you do a better job of caring for your patients. I don't claim in my presentation tonight to be a great teacher or a great surgeon. I'm an old surgeon, a tough old trauma surgeon. I'm here to tell you about my mistakes, my errors, and help you learn from them, I hope. And any wisdom I have is from 40 years of being in the field that you're in. And what then are we all about here tonight? What can we talk about tonight? Well, I think it's important to point out that there are still critics of the MGB. MGB is a superb surgery, but there are tricks and traps. And we know that because we see complications reported, including death, leaks, bile reflux, revisions, still thinking about it as the old Mason loop, less like an antrectomy in Billroth 2. So for all of these reasons, there's still a problem with the MGB. It's being adopted. It's being adopted. What we want is to have it done well. That's our goal. People are suffering with complications. People are dying unnecessarily. The MGB is simple and nothing special. That idea in many people's minds who are trained as Roux-en-Y or sleeve or lap band surgeons leads to reflux, ulcers, and it can be deadly in unskilled hands. The MGB, I'd like to show you, in 17 years ago, we did the MGB in this one particular video I'll show you briefly in 19 minutes. So I'm going to switch videos for a second. Just give me 1 second, please. So here's an animation. This is from a video. And again, this operation was done with 2 people only. There was the surgeon, myself, and an assistant. And the operation done back in 2003, and you'll see some old techniques. I'm going to skip through the whole thing, but this only took 19 minutes. I don't say that to brag. I'm embarrassed about it. I hope and no one thinks that there is an advantage of doing an operation quickly and poorly. On the other hand, when you understand the MGB and do it well, it is an easy operation to do. As you can see here, this is the only surgeon at the operating table. I stand at the side of the patient and I have an assistant, and that's all. And again, the MGB should not be attractive because it takes only 19 minutes. It should be attractive because one of the most powerful, one of the most adaptable, one of the most successful operations that can be chosen for bariatric surgery now can be done in almost the straightforward, simple, direct way so that you can think about it more like a colonoscopy. Simple and direct, making the patient well, leaving them soon able to eat, move, and return to their life with success that outweighs almost every other operation except those of the most dangerous and distal bypasses. So here you'll see basically what we'd like to demonstrate is the surgeon standing straight up, and we'll watch the arms as he works. And what we want to see here is a 90-degree and using fingertips. So we'll skip ahead a little bit here. And so we see this 90 degrees, standing straight, no bending over, no legs up in any kind of compression, risk of pulmonary embolus. And this operation, as I say, very brief. And we'll skip over this. And this is suture with an everted anastomosis with the old endo stitch. And I'll stop there and switch to something else. But that's a brief look at an old operation that can be done very easily now. And many people agree it's one of the best choices. Now I'm going to switch to another topic here in 1 second. All right, 1 minute, and now I talked a little bit about the surgery. Those of you who are experts, this will be a little bit of a routine, but we will start to talk about some of the details of the procedure. And again, it's standard general surgery. There's nothing new or unusual about it, except that people don't understand it. When people criticize the MGB, they're criticizing a 120-year-old operation, a 140-year-old operation, antrectomy and Billroth tube. The callus gastroplasty, for example, is unique in this case because it's non-obstructive. If you think of the sleeve, the Roux-en-Y, and the lap band, they're all designed to make an anatomic obstruction as a mechanism of decreasing weight, and they always fail. The anticolic Billroth 2 loop is a simple technique, but it's allowed to be tailored to the bypass, to the patient's needs, and again, we'll talk about that, and that's widely misunderstood. And I'd be happy to go into more detail about that later. The advantage is simple, elegant, effective, durable. If you want to join my Facebook page, you're invited. Talk to thousands of my patients and others who are 10, 15, and 20 years after their MGB. Let me emphasize that again. Right now, skeptics, people who are interested in the MGB, can join Facebook on my pages with thousands of MGB patients who are 10, 15, and 20 years after their MGB. Not only that, at the same time, you can join other sites that have sleeve patients and Roux-en-Y patients, including one that I recommend called Weight Loss Surgery Ruined My Life, and look at sleeves and Roux-en-Ys and some of the sad, sad outcomes. The MGB is durable, powerful, can be tailored to the patient, and it's reversible and revisable. These things all take some time to talk about. I'm happy to talk about individual ones, but for now, let's do an MGB. These are the ports I use. Again, my mean operating time from 10 and 15 and 20 years ago was 36 minutes. We dissect the lesser curvature at the junction between the body and the antrum at or just below the crow's foot. Note here the angle here, we're going to try and bring the staple gun in from above down. We often see this error is made by surgeons where they bring it up, they sit between the legs, they bring their staple gun in below, and that makes a bird's beak defect, and we'll show you examples of that. They think they're being clever, but they just don't understand the MGB. So what we're going to do is do perpendicular. Now a lot of people have learned about the long pouch that are going down in the antrum. That's a bad idea because you have big, bulky, thick antral tissue, highly muscular, and that affects the gastrojejunostomy, causing bile reflux, increase, marginal ulcers, and partial obstruction. Here we're going to talk about this tip and how important that is, and then a lot of surgeons are confused. They think that this is a sleeve, and so they make a tight, narrow pouch. That's wrong, and we can go into details to try and explain that to you. Here is this what we call the cobra head, and again, we're going to talk about this distance. We're going to talk about this staple line, and the gastrojejunostomy. We're also going to talk about the courses that I go to. When I go to talk around the world, there are many people talking about sleeves, and they're polite to me after they talk about sleeves, this and that. They'll sometimes ask my opinion, and oftentimes they regret that. But one of the things you'll notice up here is the area near the EG junction. And we notice in this drawing that we're intentionally staying away from the EG junction. And as you may know, a lot of sleeve surgeons, Roux-en-Y surgeons, and new claim to be MGB surgeons dissect and repair the hiatus. This is not what the MGB is. If you want to do that, you certainly can. Please don't call your operation the MGB. But when I'm at these other meetings and sleeve people talk, they always talk about something called stents. Stents, because sleeve people talk about stents because they get leaks. And frequently they'll politely turn to me and say, Dr. Rutledge, what is your opinion about stents? And I say, I don't know nothing about no stents. We don't use stents. We don't have leaks at the EG junction because we don't go there. And so there are fine points that we can talk about in that area as well. These are topics that we could discuss. The gastrojejunostomy staple line is here. We often see it put out here, anterior and posteriorly, and we'll show you some videos of those kinds of mistakes with questions later on. This is the tip gastrotomy, enterotomy, staple, closure, either with sutures or staple. So again, that's a brief look at the MGB. It's a relatively straightforward little case, can be done easily, and plus it has the amazing capability of being tailored to the patient. So for example, if you have a severe diabetic, you might wish to have more power in the operation. In the sleeve, or Roux-en-Y, in most classical Roux-en-Y cases, the case is a case is a case. In patients who have more deadly complications of diabetes, you might want to choose a more powerful drug, or in this case, a more powerful operation, and the MGB gives you that capability. The MGB, as I say, can be tailored. The usual bariatric patient, super obese, GERD patient. I'm happy to talk about this. A lot of people get confused. The MGB actually treats. It doesn't cause gastroesophageal reflux. It's good for the difficult patient because if you have somebody who you'd like to do an operation, but if they are not a good candidate, the MGB is valuable because it's so easily reversible. A borderline patient similarly, and plus Dr. Kular and I have shown that it's useful to use a modified MGB even for non-obese diabetics. And with the new pandemic of diabetes that's coming to India, it's important, I think, and valuable to know that we have a treatment that's much less expensive than some of the newest drugs. Dr. Kular's 10-year data demonstrates good long-term remission up to 10 years after his initial MGB, and 10 years of $20,000 a year for the drugs that are now being offered to the diabetics, the GLP-1 and SGLT2 drugs, makes the MGB appear cost-effective. Okay, now switch to one other topic. Okay, I'm going to briefly show you some of the mistakes. These are video pictures that I got off the internet and from surgeons who've shared their videos with me. And these are what I would call mistakes that can harm and kill people. Here's a step, and let me orient you. Here's the left hemidiaphragm, the left lobe of the liver. Here's the lesser curvature, and down here is the crow's foot. And you see the staple gun and the dissection coming in, and the dissection up here. So they're going to ultimately, as we'll see in the next picture, shorten the pouch tremendously, and by turning this angle from the right way to the wrong way. So let's look at the next one. So here's the staple gun, and you see where it is up here, whereas the crow's foot is down here. So they've shortened the pouch, and by shortening the pouch, you increase the damage of the bile that might normally reflux in and out of the stomach and the stomach pouch. Here is the staple line right here. I don't know if you can see it, but in other words, here's where it should be. Here's the crow's foot, And here's what you see is what they've done is the wrong surgical technique. And this is by a surgeon who advertises himself as an MGB surgeon, as being, he says, trained with me. I don't know him. And so it's a matter of concern. Here's another example of a common error. So here's the distal staple line on the gastric pouch. And here's a gastrojejunostomy. Okay, so now staple line here, there's no blood flow coming through here because this is divided tissue. How does this tissue get blood flow? So they've created an ischemic suture line at the gastrojejunostomy here. And so that means this patient is a setup for bile reflux gastritis, and marginal ulcer perforation. He also split the omentum. And now we're going to look at some of the other obvious errors, the twisted pouch and the anterior gastrojejunostomy. Okay, again, look at this is usually probably a surgeon sitting between the legs. This is a surgeon who actually I think used to be a friend of mine. And I was a little bit critical of his technique, and so I haven't heard from him in a while. But if you look at the staple gun here, the angle of the staple gun is the red line here, aiming up towards the diaphragm. That's not what we want. We want to go perpendicular to the lesser curvature down here, because what you're going to do is ultimately you'll have a pouch, but you've shortened it by maybe 10 or longer centimeters. Also, you're making this tip very narrow, which again is not the correct way. Here it is again, narrow pouch, wrong angle. This is the correct angle. Here it is, bird's beak. So even though he started here, because this is so narrow, really where the pouch is going to begin is going to be significantly up here, plus it's tight and narrow, so it may be more like a sleeve type obstruction or like a lap band. Here's another example. This is going to be a gastrojejunostomy, but he's suturing it and he didn't do a staple line. He's just going to take this 2 or 3 millimeter defect and sew it to the stomach pouch. So he's going to have what would be appropriate for a Roux-en-Y in their theory, but it's not correct for what we would recommend for an MGB. It causes obstruction, so if bile does, as it will, reflux, then automatically it tends to be delayed in its emptying, so the bile sits on the gastric mucosa. And if in addition the gastrojejunostomy has a relatively ischemic area, you make a setup for marginal ulcer, gastritis, and bile gastritis. And this is just a further example of this tight, narrow, purse string type closure. So it's a devascularized tip of the gastric pouch, a twisted gastric pouch, staple on the lateral aspect of the pouch that creates a staple line defect. The combination of these 2 to 3 centimeter severely ischemic stomach and massive titanium staples means a high risk of ischemic and foreign body and marginal ulcer. So technical issues, oh, sorry. Oh, well, I guess I skipped that one. Here's an example, very, very similar. We see this all the time. People think they're being clever. Look at this tip. Okay, this tip began at the lesser curvature. Now think about that. This tip began at the lesser curvature. And now where is it pointing? Sometimes in some of the other pictures you're going to see, this tip will rotate all the way around. If you have this kind of candy cane, twisted type of gastric pouch, it's going to be dysfunctional. The patients will tend to have reflux. And this occurs often with people sitting between the legs or not understanding that we want to come perpendicular down here and make a wide base of the gastric pouch. This is bile reflux, nausea, vomiting, excessive weight loss, ischemia, and marginal ulcer, all because of this twisted gastric pouch, which if you look at videos, very commonly people will talk about that, and most commonly when you see surgeons who don't know what they're doing. Here is a devascularized tip we're going to look at. Look at the tip here with a clip on it. So again, wrong, completely wrong. Now this is a gastrojejunostomy, And what they've done here is they're suturing, they're stapling to the anterior surface, okay? The reason is they have a low port sites with a twisted pouch because of poor positioning of the first staple line. That begins the twist. The second common error is a short posterior pouch wall. Let me think if I can explain that. When you put the staple gun in, you can make either a larger or shorter posterior wall. In other words, the new pouch is created just like the gastric wall of an anterior and posterior wall. The anterior wall, if it's equal to the posterior wall, will keep the normal medial lesser curvature to the neo greater curvature relationship. But when the shoulder of the surgeon drops, you tend to make the posterior wall shorter and shorter, twisting the pouch and creating the twist and obstruction. So this is a short posterior wall versus a long anterior wall. These two errors lead to that twisted kink. And again, up to 180 degrees or more. It makes an anterior gastrojejunostomy seem like a good idea, and that's wrong. Now this is what it should look like. This is what it should look like. This tip here is the lesser curvature. And look where it is. It's medial. That's what we want to see. This tip should be here, not out here, and certainly not all the way over 180 degrees over here. This also is wide, so that means there's a lot of opportunity for vascularity, both here, which you can visualize it anteriorly, but also posteriorly. Now here's, this was actually sent to me by a friend, and that surgeon is still a friend of mine, so I take honor in that. But this, look at this tip. This is almost this is, look at this. This is the lesser curvature, and this is the lesser, the lesser. I mean, this is terrible. How do you, now this patient looks like he's a good, or she's a good candidate for a gastrojejunostomy, but that's unintentionally going to create an obstruction. Okay, and that patient and the doctor called me and they said, we're vomiting, I can't do that. And I said, re-explore, and this is what they found. And they looked back. I like this so much, I put it in there a bunch of times. This is one where this is one a couple of months later after the surgery. The patient had persistent nausea and vomiting, and you can see it had a 180-degree twist. So when they were running the bowel, they got the loop twisted, and so this is what turned out with that. So again, I guess everybody knows that's wrong. Okay, here's a good staple line. This is a good start. But now we're starting to go off. Okay, this is that second firing. And the second firing, the first firing was good in this particular video. This is another former friend. And the first one was good, but then this is clearly wrong, clearly wrong. And now look, what's happened to the tip? You see, when they put this in, they're not paying attention to the placement. And so look at the tip. Look at the tip right here. Wrong, wrong, wrong. So this again, it looks like it would be right. This should be laying flat. There it is. There it is. And look, the staple gun's coming in from the wrong direction. I won't talk about this. Is the blunt dissection of the EG junction, which we disagree with. Wrong angle for the stapler. It should come in parallel to the long axis of the tube. And now here's the correct angle, and what they're doing is closing it in the negative wrong angle here. You get this ugly lumpy anastomosis, which just decreases the diameter of the gastrojejunal junction. Here's some dissection of the EG junction, and I have a video where they dissect into the left hepatic vein. So that's all on that one. Now I have one more, and then we'll open it up for questions. So what I'd like to go over, here's just some of the things that we see that damage, hurt, and ultimately kill people. Of new surgeons who see this short, simple operation and think they can do it and use their knowledge of the sleeve, the Roux-en-Y, or the SATI or SASI or other single anastomosis operations. Short pouch, twisted pouch, candy cane twist, narrow pouch, pouch stricture. BP limb too long, BP limb not understood, stricture of the gastrojejunectomy, kink of the gastrojejunectomy, reversal of the BP limb, ischemia of the gastrojejunectomy. And when I have had the opportunity to see many of these patients, they'll call me, or the surgeon will call me, and we go and evaluate them, either the original video or a post-operative study. We can see these kinds of problems. So what we think is there are these and plus other problems that lead us to an idea, which we're going to talk about next.
Thank you very much, Dr. Rutledge. I think everybody was looking at you, watching your video very closely. We know mini gastric bypass is a simple, short operation, but at the same time, as we see, it is being looked at like a very strong operation, which can even cause malnutrition as well. As far as I understand the concept, the mechanism, with mini gastric bypass, like Dr. Rutledge showed, we have a long, narrow tube, which is essentially of the same diameter as that of the esophagus, or maybe a little bit more diameter than the esophagus, but not less than the esophagus. So it's just a delivery tube which delivers the food right away down into the loop, into the jejunum. And that is what we see after 10 years, after 15 years, why this procedure is now showing a very good sustained effect on the weight loss. Because as Professor Tolini from Italy has studied the pressures inside the gastric tube, we understand that because of the wide outlet, because it is a non-obstructive functional restriction, like a wide bore feeding jejunostomy, patient is eating into the loop, and the loop changes the eating habits of the patient. They cannot handle too much too fast. They cannot handle too much of sugars, too much of oils, too much of fat, too much of carbs. So this is what gradually changes their eating habits. Professor Rutledge looked at his data and we asked the questions to these patients about what kind of change they have in the eating habit. And it will now be published very soon. It's very interesting to understand that it is not only the malabsorption of the mini gastric bypass which is working after 10 years, after 15 years. Actually, it is the change in the eating habits. Like we used to see the post-gastrectomy syndrome diet, you know, it comes from our basic general surgery knowledge. The post-gastrectomy syndrome, these patients need a Mediterranean kind of diet. And that is what happens to the mini gastric bypass patients. And the pouch doesn't dilate because the outlet is wide. So what Dr. Rutledge was impressing upon by showing the video, we don't need to twist the outlet. We don't need to make a tight outlet. We don't need to put a ring on the outlet to make it obstructive. What all we need is the food should come down directly into the loop, and patient can start eating easily, start eating quickly after surgery. On next day of surgery, patient can actually start eating solids. So with the concept now, totally changed. We started from restrictive procedures with very tight pouches like micro pouches, and now we see MGB as a strong procedure which can even lead to malnutrition. So we see patients coming from different backgrounds showing different effects. So that is why now in India, most of the surgeons, they want to give a shorter bypass as compared to the American patients. They can handle longer bypasses. So probably the amount of protein which you are eating, the kind of diet which you are taking matters a lot. So Dr. Rutledge, do you have anything to say about the long-term and the functional restriction of MGB as compared to the obstructive restriction, which was a commonly understood concept of weight loss surgery in the past year?
Yes, thank you, Dr. Kullar, and good points. If I could, I'll show you just a few slides on this topic. So the idea, as Dr. Kullar said, is what's the difference between MGB and say a Roux-en-Y or a sleeve? And some people think they know, like often you'll hear the word malabsorption, which if we could, I'd be happy to talk about that. Or they'll say that the MGB and the Roux-en-Y are similar or the same, just the difference is the one anastomosis. So let me show you what I find when I talk to patients, especially in the past 9 months in the pandemic. I've had a chance to talk to several hundred post-op sleeve, Roux-en-Y, and MGB patients. And as you said, I have some new research on some of those findings. But let's look at what I would say is a simple way to think about obstructive restriction, which is the band, sleeve, and Roux-en-Y, and the non-obstructive restriction of eating that occurs with the MGB. And it explicitly does not want a band. We don't want a band. We don't want a tight, narrow pouch, and we don't want a tight, narrow gastrojejunostomy. So let me see if I can explain that. So I'll go here and share. 1 second. So this is a question I ask of sleeve patients and MGB patients, and particularly I want to point out the vertical banded gastroplasty, an operation I did several hundred of until I abandoned it. The band and the sleeve, when I talk to people who've had a band or a sleeve and often a Roux-en-Y, if they can eat broccoli, an apple, or a big sandwich, and most of them choke on those foods. Many people say they can eat them, and if they chew them for 36 times, but then I ask them if they have eaten them, and they say no. And then I will ask them, could you eat a Coca-Cola, ice cream, or candy? And they say, yes, but I don't. And I accept their opinion, but they say that healthier foods in general are obstructed. That's what happens when you have a tight, narrow outlet. You have obstruction and restriction. But they restrict healthy foods, and they tend to allow easily the passage of unhealthy or sweet-eating foods. But not just sweet-eating foods, high-fat foods as well. So what we think is the process of failure of the vertical banded gastroplasty, the band, the sleeve in the future, and the Roux-en-Y is a relative obstruction leads to weight loss. But then there's increased hunger, decreased satiety, and healthy foods are blocked, and there's a drive to eat up with more of these unhealthy choices. So this is the obstructions that we can see in all these cases. So apple, sandwich, and broccoli, no. And ice cream, Milky Way, and Coca-Cola's, yes. So we think that it's really important when you're creating the MGB to understand we don't want a band. We don't want a tight, narrow gastrojejunostomy. And I have videos of surgeons creating, you know, a gastrojejunostomy that would be very appropriate for the theory of a Roux-en-Y, but not appropriate for an MGB. We believe in the wide open connection, and that the idea of the tiny pouch and the tiny gastrojejunostomy of the Roux-en-Y doesn't seem to be as effective, in my experience, on talking to people and individual patients. The patients who have these tight, narrow outlets generally are regaining their weight because they're eating an unhealthy diet.
Right, Dr. Rutledge, there is another question from the floor about the length of the gastric bypass. So what do you have to say about that?
I have some things about that. As you know, Dr. Kular, and Dr. Kular, you and I have been talking about this, and I'll begin by saying we fear the MGB's long bypass. That if you read Dr. Kamal Mahawar, he talks about death after MGB from long bypass. Bypass is too long, only 150, do not go 200. Well, let's look at some data. Let's look at some data on this topic, because I think there's a lot of misunderstanding on this topic as well. Okay, to understand this fear of bypass and how much bypass and what the dangers of the bypass, I'd like to talk to you about SADI. And of course, SADI is a BPD, that is a biliopancreatic diversion. And the common channel of the BPD was initially 150 centimeters. And we're going to come back to that. But this is from the obesity surgery, this is from IFSO's website. I'm going to give you some of the comments about this from IFSO. But basically, remember, SADI is a sleeve gastrectomy, so they add obstructive obstruction. So they start off with a sleeve. Well, I thought the sleeve was supposed to be good. So the people who invented SADI say, let's have a sleeve first. Well, okay, if you have a sleeve, then how much of a bypass do you need? Well, they need a lot of bypass, because they bypass almost all of the gut. And remember, the average length of the gut, let's say, is 6 meters. So they're bypassing 4 meters. That's a huge 400 centimeters, a huge bypass. So they say, we're going to give the patient a sleeve first. And then on top of that, we need to bypass 4 meters of bowel. And I'm going to go over this a couple of times. I find when I talk to most surgeons, they don't quite understand this. So I'm going to go over it, and I hope you'll forgive me. All right, so it's a biliopancreatic diversion. It's a sleeve gastrectomy, which notably is irreversible. And we know the sleeve causes GERD. The numbers are 30 or more %. So now you've created quite a situation. Then you have a biliopancreatic diversion with a massive bowel bypass. And of course, the duodenal leak is one of the most devastating known to general surgeons. This is from the IFSO website. BPD most complicated, highest risk of death, malabsorption with lifelong supplements necessary, risk of excessive weight loss, risk of iron deficiency anemia. The sleeve, of course, has severe GERD, nausea, reflux, and diarrhea. Increased stool frequency 2 to 4 times a day, and foul flatulence and diarrhea. And I'll report one of my friends from Belgium, who you probably all know, said he didn't want to be known as the stinky poopy doctor anymore, so he was giving this up. Okay, let's go back to what we know from general surgery. What we know is this is a study from 1935 of 257 patients with bowel resection. Okay, this is general surgery. Leave out what's some comments from bariatric surgeons who like the sleeve or the SATI or whatever. This is general surgery. They found in 257 patients, if the bowel resection was less than 1/3 of the length of the bowel, that the incidence of excessive weight loss was absent. They all had normal bowel function. Okay? That is, resect a small amount of gut, and like the MGB, normal bowel function. If you lose more than 50%, and remember SATI bypasses 60 to 70%, they frequently, up to several percent, had short bowel syndrome. Okay? And here we also know adults with short bowel syndrome usually weigh between 50 and 75 kilograms. Previous studies using standard treatment suggest if you have a bowel length of only 50 or 70 centimeters, common channel, then you can probably get off TPN. This is a study from 1997. So how much bowel do we need? How much bowel do we need? How much bowel do we need? And how much of a bypass is dangerous, leading to reported malnutrition after MGB? Let's look at this again. Here's MGB versus SATI, okay? So if MGB, let's suppose the gut is 6 meters. And let's suppose we bypass between 1.5 and 2 meters. That means the common channel is 4.5, 5 meters. So we bypassed about 30%, which in the previous study is safe. On the other hand, SATI with a 6 meter bypass means the common channel is, say, 2.5. Now I think they've increased it, but that's bypassing 60% of the gut. MGB, if there's 8 meters, which is common, that's bypassing of the MGB only 20%, and the SATI is 70%. And remember, all you need to survive in this other study is 50 to 70 centimeters. And the people who are at risk are these BPD people. And the MGB has lots of gut. But now I'll turn back to our recent research that we're talking with Dr. Kular. So I'm going to shut this part down and just talk to the group. We have new suggestions in our experience with patients that when we have a patient who presents with what is being called excessive weight loss, that the treatment is immediate reversal. And when you treat that patient with excessive weight loss with food, with intravenous TPN or nasal feeding, they frequently have passed away in the hands of other surgeons. So in Iraq and other places. What we hypothesize is that the death after an MGB with a bypass is not from an excessive bypass, it's from a misdiagnosis and a mismanagement of small intestinal bacterial overgrowth syndrome. That's also called, in our old general surgeon names, blind loop syndrome. Blind loop syndrome presents with low albumin, malnutrition, and other findings. And so we believe that it's very important to educate surgeons on this new approach to these patients. They need aggressive diagnosis and treatment for C. diff type bacterial infections and other treatments, because often in the hands of surgeons who treat these excessive weight loss with TPN, etc., they have not done well, including death. So we believe there's something new on the horizon, and we'll be publishing on this soon.
Yes, Dr. Rutledge, there is another question from the floor about the new nomenclature of the mini gastric bypass, which comes as one anesthesis gastric bypass. And we understand that if you look at the literature, one anesthesis gastric bypass was started as a different procedure by Professor Carbajo in Spain in 2002. So how do you explain the differences between one anesthesis gastric bypass and mini gastric bypass scientifically?
Well, we love and respect Dr. Carbajo. His results are spectacular. He's been in one hospital all this time. His results are good follow-up. And so we have no criticisms with his operation. We love his operation. We respect him and his good results and his careful follow-up. We do a little different operation, and we think that naming both operations as a one anastomosis gastric bypass can be confusing. So what we recommend and what we're going to be doing is we're going to identify surgeons who want to offer specifically the mini gastric bypass as different from the one anastomosis. Now, IFSO has declared that one anastomosis bypass will be correct for both our MGB operation and his original OAGB operation. So I think it's confusing in the literature. And that's why I think there's a lot of confusion about how the technique should be done. One of the reasons that, of course, Dr. Cuellar, Dr. Elan in Tijuana, Mexico, and I are working to create a new MGB review corporation is we'd like to help patients and surgeons identify what kind of operation they're actually getting or doing. And we do believe that there are people who do all kinds of variations on the MGB and the OAGB. And so when you see a complication like in the Y omega trial, it's hard to know whether the operation is bad or the surgeons are bad. So we think Y omega is the poster child for telling us we need to tell people exactly how they should be doing their operation. And the MGB is a different technique than the OAGB-Carbajo, and the MGB-original technique is different. And all of them are lumped under OAGB according to the journals and the other significant agencies, but they are, I think, significantly different.
Okay, I think they need some details. Can I show a picture about the OAGB? How do you see the difference from?
Yeah, well, we can just say it's not rocket science. The surgeons who do, you know this, Dr. Cuellar, we just saw them demonstrate it. They make a narrow, tight pouch. They dissect the EG junction and repair the hiatus. They do a gastrojejunectomy, but then they do a significant and relatively long anti-reflux suturing. And they also bypass a significant amount of gut. I think they bypass 40%. So if you want to put that into the average patient, the average patient, say, is a 6-meter bypass or say 8-meter bypass, 40% is going to be 2-3 meters. So it's quite a long bypass.
So that means these are the basic differences. With OAGB, you have a very long bypass, and for a typical OAGB, you have about 60% of the intestine bypassed. And then you have about 8 to 10 centimeters of the jejunal loop, which is pasted to the stomach tube to give some anti-reflux effect to the procedure. So that brings another difference between MGB and OAGB. In MGB, you have almost an end-to-side anastomosis, and in OAGB, you have a side-to-side anastomosis with about 10 centimeters of the jejunum, which has to be sutured to the stomach tube. But this makes a difference when you are reversing or revising this procedure, because this 8 to 10 centimeters of the gastric tube, you have to either take out, or I mean, it's very difficult to dissect and separate the jejunum from the gastric tube when you are reversing. So a reversal of OAGB and reversal of MGB is altogether a different technique, and then the length is more in OAGB as compared to MGB, where we are generally using smaller lengths, like on an average about 180 centimeters. Am I right, Dr. Rutledge?
Well, I think I think that we are not the experts to talk about OAGB, so I'd prefer not to say too much. I would say they have a good operation. The details of how it's done should be obtained from the leaders, the people who are knowledgeable about it. That's for them. I think you summarized it, and we summarized it. There are some differences, But what we think is, don't be foolish and think that you've heard a little bit here and a little bit there. If someone's asking about that, they need to learn it in detail. And the fact that someone could look at this and say, I think I'll do an MGB or an OAGB, you wouldn't do that for a hernia repair. You wouldn't do it for heart surgery or brain surgery. And the deaths and complications that are being reported with MGB and OAGB demonstrate that you need to learn how to do it. The Y Omega trial tells us they stopped doing MGB surgery in France because they had some relatively unexperienced surgeons who did Roux-en-Y, are probably good surgeons, and they reported that they read one paragraph in my first paper and they thought they could do MGB. They had an MGB expert on the panel and he reported to me personally, they never asked him how to do it. So don't do the MGB unless you get adequate, good training. There are tricks and traps. You saw just a few dozen that I showed earlier. There's a lot of things that can go wrong if you do an operation poorly, but all of us are general surgeons. We shouldn't have to say that.
There's another question from the floor, Dr. Rutledge. If the patient is having a symptomatic hiatal hernia, should it be repaired at the time of MGB? What do you have to say on that?
Yeah, so in my series, I have done thousands of patients. I never touched that. And again, I have another example of why surgeons should read about this and learn about it. But there's a good study, a good example where patients were having their operation claimed to be an MGB, and they were taking the small bowel and attaching it to the stomach. Now you might say, well, what has that got to do with your question? So let me say this again. Remember, if you have the gastrojejunostomy, it wouldn't be a bad idea. Why don't you anchor it to the stomach? Because why? It'll take the tension off the gastrojejunostomy, right? And that's what this surgeon was doing. 2 sutures on either side. Why? When he does that, he eliminates the advantage of the MGB. The MGB puts tension on the gastric pouch. What does that do? It reduces the hernia. It reduces the hernia. So one of the components that makes the MGB successful in treating bile reflux, in treating gastroesophageal reflux, in treating Barrett's esophagus, is that it is an anti-reflux procedure. So you look at Carbajo's study, your study, my study, patients who come to us with reflux, and we have, you know, Dr. Reinwald, Dr. Hargroder, who's listening, Dr. Elon. I mean, what we see, what I see is that the MGB is an anti-reflux procedure, not if you twist it, not if you make a tight gastrojejunostomy, not if you make an ischemic outlet where there's irritation and gastritis. But look at the topics, look at the components of the MGB. Number one, obviously patients lose weight. That makes reflux symptomatology better routinely, even if you don't operate, if they lose weight. Number two, we change their diet, okay? So that they're not having obstruction, not like a sleeve. I mean, sleeve reflux is 30%, even if you repair the hiatus, right? So there is non-obstruction. And number two, most importantly, you make it a low pressure system. That means there's no resistance to outlet. That's why you don't have problems in the midst of the length of the esophagus itself. The esophagus itself doesn't get problems in the middle because there's no resistance in the middle. Okay, so we have no resistance in the gastric pouch if you make it correctly, if you twist it and kink it and make an outlet problem. And then on top of that, most valuable is we hang the small bowel off of the tip of the gastric pouch. That's an anti-reflux procedure. And it works very well if the rest of the components are done well. It works poorly, like when patients call me and I can find the video of their original surgery, you'll see all kinds of terrible, crazy stuff because they're Roux-en-Y operations being done as an MGB. If you make a small, short gastric pouch and you make a tight gastrojejunostomy, no bigger than 2 or 3 millimeters, that's what they'll sew together and call it an MGB. Those patients, it won't be surprising to you to tell you they have reflux.
Right, right. So, so you are emphasizing that we should actually not be dissecting the G junction, not dissecting the crura, not even looking at the hiatus hernia, and just to go ahead with the mini gastric bypass and see later on, 6 months later on, or maybe 1 year later, if still the hiatus hernia is symptomatic, then we can go in and repair it. Is that what you mean?
But even more than that, I don't have any people like that. I have never touched the EG junction. Even with paraesophageal hernias, I send them back for evaluation a year later. Nobody has had to go back. Now, I'm sure there are people that have been taken back for Roux-en-Y's after my surgery, but here's the thing. It's an extremely low rate, and if you look at the treatment, what would be the treatment for severe esophageal reflux after an MGB? Sometimes people recommend after sleeve or Roux-en-Y or sleeve or MGB, they say, oh, do a Roux-en-Y. You should look at the data on Roux-en-Y's over the long term. 45, 70% are taking PPIs. Many people are still having complications. Many people still have dysphagia. And many people don't appear in the studies. Again, I recommend you go to Facebook and look on some of the Facebook pages of people suffering from Roux-en-Y's. It's not a pretty picture. And the MGB, you know, in your own patients, and certainly in my patients, the MGB does well if it's done well. And the other case where you'll see reflux symptoms is where patients have gotten off their regular type of food that an MGB allows the patient to eat. It takes a few minutes to go into that, and I don't know if you want me to talk about it, but when patients violate the basic 6 small meals, it's not the MGB, it's called the post-gastrectomy syndrome diet. It's been there since the 1920s. 6 small feedings, relatively low and high fat, high meat type foods. Those things can cause reflux even in a well-done MGB, but as soon as you modify that diet, those people tend to get better.
Good. I have my friend, Professor Hargroder from US. He's with us today, and I think we should ask him as well because he's a leading MGB surgeon in US at present, the busiest MGB surgeon in US. And Dr. Hargroder, what do you have to say about the hiatal hernia thing, and what is the incidence of the reflux in your series?
Yeah. Well, thank you. I appreciate it. It's morning time over here, and I'm enjoying this very much. I am going to have to leave in just a few minutes because they're calling me to the OR. But I agree 100% with Dr. Rutledge. I've probably got about 1,800 cases now, and the incidence of reflux that I see is very low. It's I don't have the exact percentage. It's probably 2 or 3% right now. And I stay well away from the GE junction. As a matter of fact, I even will angle kind of as I approach the GE junction, angle out just a little bit, just so you don't even have to touch this.
Good.
Yeah, and ask if you do that, how many leaks and how many stents have you had to place?
Yeah, 0 up at the GE junction for sure. And it should be a non-existent problem, unlike the sleeve.
Right. Good. Thank you, Dr. Hargroder. We have another friend from Germany, Professor Karl Ranwald. Dr. Ranwald, what's your opinion about reflux and fixing the hiatus at the time of surgery?
Hi, thanks for this question. Actually, we are operating on very high BMI patients, and usually we don't touch the hiatus either. And concerning reflux, we have the experience as well that it gets improved in many cases, most of the cases. And we end up with a rate of reflux problem on the long run with certainly less than 5%, where we treat first conservatively, and only if there's a persisting problem we would touch it with a revision, with an operative revision. But we don't touch the hernia in the primary intention either, because we got, as Dr. Rutledge said, you have this traction on the pouch, which is reducing the hernia. Many patients have asymptomatic axial sliding hernias of the hiatus, which get reducted, and also we get the anti-reflux effect from the low pressure system. as well as the weight loss also is creating some degree of anti-reflux mechanism, because your pressure in the abdomen is decreasing after the operation as a result of the excellent weight loss effect of MGB.
Right.
Dr.
Thank you,
Kular?
Dr. Ranwal. Yes, yes, Dr. Rutledge, you have to say.
Can I ask Dr. Reinwald a question?
Of course.
Dr. Reinwald, sir, hello, and hope you are safe and happy holidays.
Thanks, Dr. Rutledge.
If you have a patient ever who has reflux symptoms after MGB, it would be an honor for me and educational if I had permission for you to let me speak with them.
Okay. Okay.
Because I have been doing that for the past 9 months, and what I have found is it oftentimes a minor dietary change can resolve it.
I
Yeah,
agree.
yeah.
Okay. Okay.
Yeah.
Thank
Yeah, this is very important, what Dr. Rutledge is saying. You know, sometimes we have a patient who complains of reflux. Actually, it is not because of the loop. Sometimes the patient has a new marginal ulcer. And when the acid touches the ulcer, when the food touches the ulcer, there is a spasm. And that is what starts that new reflux in that patient who has not seen that reflux for maybe 5 years, 10 years after the surgery, but suddenly the patient starts having reflux. Or on and off, maybe once in 2 months or once in 3 months, sometimes the patient has regurgitation while sleeping, you know, when they go to bed early after eating an oily meal. So sometimes they have regurgitation, and this is quite often, you know, labeled as reflux, and sometimes patients are advised some kind of surgical revision to Roux-en-Y to fix this. Yes, Professor, what experience you have about this regurgitation, and what is the difference in regurgitation and bile reflux, and how do you fix it?
Well, I was going to say, beware of oranges. Remember your patient who came to see us and he ate the whole orange and he had an obstruction, had to have it repaired by endoscopy. Yeah, I think it's really simple. When I talk to patients, and over the past 9 months, Dr. Reinwald, I have been stuck here in India. I mean, not stuck here. I'm honored to be with Dr. Kular in India.
We are blessed to have you here.
But during that time, I went to talking to patients. So I started calling patients on Facebook. And initially, when I started doing it, they thought, who's this creepy man trying to contact me on Facebook? So it took some time. But over time, I've talked to about 200 patients who have had reflux, and many were MGB patients. And the majority were skipping breakfast, eating a relatively large meal at night, and then they would have reflux. So I said, you know, just do these simple changes, cut back on meat and some other things. But here's the thing, when I try to explain to them, I say, look, peristalsis is the way food moves from your mouth to your bottom. And that is a normal but very miraculous neuromuscular system that automatically takes the food once you swallow it, and you never have to think about it again. It's a one-way trip from mouth to bottom. I said, on the other hand, let's imagine if you swallowed a cork. Okay, if you swallow a cork and it goes through your esophagus and gets to the small bowel, then of course bile and acid will tend to back up. And I said, when you're eating that big meal at dinner and skipping breakfast, you're hungry enough to eat more than you need, and you're basically swallowing a cork. And so when I just tell them that simple approach with a few other minor modifications, what I've seen is many of our good old MGBs and patients from around the world, from the UK, from Iran, from Pakistan, from the Middle East, from Egypt, United States, Dr. Hargroder, Dr. Paragli. I've made this kind of simple intervention, and they seem to get better. And I have some really good examples of patients you can see with that outcome. So I'm very optimistic that it's easy to manage this in an MGB patient. And even with sleeve and Roux-en-Y, I found that with some dietary modifications, you might be interested in us talking further sometime.
I think, Dr. Kular, you missed one question was there earlier, that somebody wanted to know that if he starts the procedure from the right side and then switch over for the second firing between the legs,
No,
Yeah,
sir.
yeah,
I don't.
right.
I can tell you that
What do you say on this?
most everyone will tell you I don't go between the legs.
Yeah. That there was a question on that. Okay.
See, if you are used to going in between the legs, then it's your own choice. But the problem with MGB is that the first shot has
Yeah.
to come from the epigastric port,
Yeah. The first
and
fire.
it will be really very difficult to fire the first shot from the epigastric port if you're standing between the legs. And then, then we fire the second shot from the right subcostal port, and then third one from the umbilical port. So this is how a typical Rutledge MGB is done. But otherwise, if you're comfortable standing between the legs,
I think nobody will be comfortable firing the first stapler from the epigastric port, which is intended to be vertical to the curvature.
Yeah, it has to be facing the feet of the patient, actually.
Absolutely.
But even the second port should not be coming from below. You see people make all these twists of their staple gun head, and they think that's clever. We think it should be like following a counterclockwise. So 12 o'clock, 9 o'clock, 6 o'clock, 3 o'clock, and then work your way up. And that will give you this wide tip, what we call the cobra head tip of the gastric pouch. And that is critical to get the benefits of what we see. And think again of the sleeve. If you think that we're making...
I think you gave an excellent, 12 o'clock, 9 o'clock, 6 o'clock, and 3 o'clock. That's an excellent trick of making the sleeve, the pouch much better, going in a very sequential way. That's probably one great thing that you emphasized upon. And the other one you always emphasized upon going for the fast fire at the junction of the antrum and the body. That's in fact just below the crow's foot. That's probably.
Yeah. And we have seen some people get over enthusiastic. They take some of my advice and say, I think I'll go down towards the pylorus. And I think that's unwise, because then you have this big bulky tissue, a mass of the muscular antrum in anastomose to the small bowel, and that leads to a stricture, a partial obstruction, because that muscular tissue is designed to contract, whereas the wall of the stomach, the body of the stomach, is designed to, in fact, dilate.
So what stapler you prefer for your fast firing or the subsequent firing? It's all blue, or that's a tri-staple? Which one is you prefer? That doesn't make.
I'm old, and so
I'm old by age, but young at heart.
Yeah, I'm old and annoying, but yes, you're very kind. I use nothing but blue, but now, if you have a very thick stomach, you've done something wrong. In other words, stretch the stomach. If you are in the antrum and you feel that you must use, a heavy cartridge, my bias is I don't want that tissue in my gastrojejunostomy. You're down in very thick tissue, don't be there, because the muscular antrum is not what we want to do the anastomosis to. What we want is perpendicular, exactly along the junction between the body and the antrum, perpendicular first, and then straight lateral, from medial to lateral, not heading. Everyone that I see is urgent to turn the stapler and start heading up to the EG junction. Don't. Make a big wide base, and I can show you some pictures if you want, but that wide base, that's where we do our gastrojejunostomy, and I didn't have time to go into it, but we want vascularity to the lateral portion of the neo-greater curvature wall. When that is not well separated and there can't be vascularity, that tissue becomes dead and ischemic. Now you have staple line from the gastrojejunostomy, ischemic tissue, and then a lateral neo-greater curvature wall. And that then becomes ischemic with extensive foreign body, and that becomes a nidus for the marginal ulcers. All marginal ulcers that I'm aware of occur on that lateral border because the surgeon himself created this at the time of surgery. If you look at the incidence of marginal ulcers, some surgeons are getting high rates and others are not. And the reason they're getting high rates is their surgical technique. Learn the right way to do it and your patients will be happy.
Okay.
Okay. From the floor, there is another question. They want to see the port positions. Dr. Rutledge, do you have a picture or should I show it here?
Sure. 1 second.
So Dr. Rutledge, you have made MGB so simple and so user-friendly. That's a great thing. Could you suggest that somebody who is starting a bariatric surgery can start off with MGB, not with sleeve? There are some.
I think, well, what we think is that, yes, with training, it's an easy operation to do. A lot of times the knowledge that people have for sleeve, Roux-en-Y, and SATI are wrong for the MGB. But let's look at this and then we'll talk more about that, sir. I'm about to bring it up now.
Okay, fine.
Can you see the picture there? We have the port positions there. Can you see the
Yeah,
picture?
coming. 1 second. 1 second.
Yeah.
I'm going now. I'm rushing.
Okay.
And thank you, Dr. Rinwald, for your contribution to this meeting. We really appreciate.
So these are the ports.
Okay.
And there's a couple of tricks with these. The number 5 port is a 5mm port. And just the other day, I saw a patient from Mexico who had a single port MGB, claimed to be MGB. It was all infected and draining. So I'm not an advocate of cutting down the number of ports. You can convert this bariatric surgery into the equivalent of colonoscopy. Imagine, simple, safe, not quick because you're rushing, not quick because you're a fast surgeon, quick because you know how to do it. Quick because you know what you're doing.
Second and third port, Dr. Atlas? From the epigastric port and the umbilical port, what's the distance?
I'm sorry?
What's the distance between your epigastric and umbilical port?
Say one more time, sir, slowly for me.
The distance, the length between the two ports, the epigastric and the umbilical port.
Obviously, it depends on the size of the patient.
Okay.
Usually, I say 2 or 3 finger breadths below the costal margins for those that are across the top. Underneath the costal margins, that should be 2 to 3 finger breadths, maybe a little more. And then the anterior axillary line for the 2 lateral ports and the 2 finger breadths, and then 1, 2, 3 hand breadths, and ignoring the umbilicus for the placement of the camera port.
Okay.
I have a picture where I can actually show you the camera ports from the outside of a patient, not in the drawing, if you want.
Yeah, please.
Okay, 1 second. Also, this is a very good, if you want to, I have a really good example of an MGB done live. I could show you that too.
That will be wonderful, please.
It may be a good way to finish up. Okay, hang 1 second and I will show you.
Definitely.
You will have it. Okay, 1 second. We're just getting ready here.
Sure.
Okay. So here's 1, 2, 3, 4, 5. There's the midclavicular line, midclavicular line.
It's almost the same way that we do a fundoplication. I mean, almost.
Yep. It's the same. That's the same target area for us too, because that's the danger zone. We don't want to go there, but we got to go there and stay safe.
We have nothing to do in the hiatus. That we have clearly told that nothing to look at. Even you don't look at that also. Good.
So here's the crow's foot. Okay. Here's the antrum, and so more aggressive people are down here thinking they're doing better. That's not better. Let's see, look at this, almost perpendicular,
Yes.
almost to the greater curvature.
Okay. That's
Blue load is wide because he's not in the antrum.
That's the 60 blue.
Yep.
Okay.
It can be even easier if you're in a smaller patient with a 45 or even a 30. Oftentimes there's no space to get the 60 in and open.
Okay.
So starting off and having a 30 available, if you're doing a BMI of 35 or something low, this can be hard to do. And also notice the delay. He compresses and delays. Go slow to go fast.
Okay. That's the first firing coming from the 12 o'clock. Then the
Right, now
second.
look also, look
the
at the
nine.
tip. You see the tip here? It's not curling over. And now see where the staple gun is? It's perfectly lateral. Lateral goes all the way out here and stretch out the stomach. And in other words, he's not trying to immediately go up to the EG junction. See this? Very good, very good, very good.
Okay.
See, he's got a little wrinkle here. He's taking his time. Very wise. Very good job.
Even if a wider pouch also doesn't matter, but it should not be tighter, closer to the. Do you put a bougie at this point of time?
No, no, don't
No.
need a bougie now. Don't
No.
put a bougie in now. That stretches and distorts the stomach. What you
Okay.
want to do is look how soft it is. See how
Okay.
soft? It's not twisted. It's not kinked. And you see the wide base. This is all going to be a base, and it's highly vascular. This is great. Now see here, see how much stomach here? This is not as good as it could be. It's very good, but it's not good. What you want to do is come out here to the greater curvature and make this a tip. Now this is wrong. This, well, maybe not. Not too bad. This is not bad. So he's going out to this. Yeah, this is good. That's good. But you see that? This is exactly opposite of what you see these other surgeons doing. They're immediately heading to the EG junction.
But you have to point away from the EG junction.
Far away from EG junction. Yeah.
Yeah. Yeah.
See, but look at this wide base. You see the wide base here? Even wider is better. But now we'll skip ahead because you don't want to watch the whole operation. Okay, now this is really important. Let me stop here. You know, a lot of people will dissect the EG junction there blindly. They'll stick stuff in there. They'll take what's it called, the gold finger, or just terrible foolishness. What is this here? Your listeners, I'm going to yell at you 3 times. What is this? What is this? What is this? That's the short gastric. Don't stick anything up there blindly, hoping that the mesentery will part before you. It might. It usually will, 99 times out of 100. But every once in a while, when you jam something up there blindly, dissecting with the blunt tip of a forceps or a lap pad or a gold finger, every once in a while, you'll tear that short gastric, and it goes here where? To the hilum of the spleen. And then you know what happens next? Suction, suction, I can't see. Here, hold the camera. Oh, no, take the camera out, clean it. Yeah, don't do this bluntly. Watch what he does. This is right. This is good. You can see where he's going. He's already almost there. Almost there. And stay on the stomach wall. On the stomach wall.
Okay.
Very good. Posterior dissection here. None of that jamming stuff in anterior. That's just foolish. And also over here, the assistant's moving and holding that up. That's really good. Everything he's doing is good. Bingo. There's spleen. And there, now, this is great. All the dissection under direct vision. Dissect under direct vision. No bluntly jamming stuff up here. I have lots of bloody videos of people jamming stuff up there and then suddenly pulling it back and getting a belly full of blood. Okay, we'll skip that now. All right, good. 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 There it is. Beautiful.
And then the fourth one comes from the umbilicus.
I'm sorry?
The fourth staple comes from the umbilical port.
No, the camera port is the umbilical port.
Okay, okay.
Okay, so now we're going to make a anerotomy, and the anerotomy should be this way, not this way. Stop.
Okay.
If you make the anerotomy, gastrotomy. The gastrotomy needs to be here, okay? If it's here, that means you got staple line, which is the neo-greater curvature, and then you're going to have a staple line in here, so that creates this bridge of dead tissue. That becomes the site of the marginal ulcer, plus it causes stricture if it doesn't cause an ulcer. And that stricture then means that it doesn't empty the bile. Bile is going to go up into this pouch as it goes into our stomach. What we don't want is a twisted, kinked, or inflamed area where it doesn't come out.
So you keep 2 centimeter distance between the staple line. On the anterior part, you make the gastrotomy. Am I right?
Step number one is put the staple line out. Very far lateral, make a cobra head. So you have staple line here, that gives posteriorly and anteriorly the collateral blood flow from the wonderful lesser curvature. But now what we see, a lot of people is they'll do staple line here, it'll be tight and close to the lesser curvature. So now these two are right next to each other. Then they'll put the staple line in, and so they narrow everything and make it ischemic. And I showed you a bunch of them, probably too fast, but this is the crux of the surgery. And everybody that I see that has trouble does it wrong. So we won't go on forever, but run the bowel. There's a whole bunch of stuff we could talk about there. Now here we're going to do here we go. Staple line here. This is the neo-greater curvature. Here's the staple line, and now we're doing the staple. This is the loop of bowel, and here's the staple cartridge. And now they're going to fire. But look at this. You see this distance here? If you take this staple line and put it next to that staple line, all that tissue is dead. If you give it at least some chance that some collateral could come up this way, then you've got live tissue. So that's the critical difference there.
Okay.
Now here we got our gastrojejunostomy. So now here's the beautiful part of this. We have a bunch of others. This is really technical, but this has no staples in it, and this has no staples in it. The staples are here and here laterally, but this has no staples. If you look at how other people do it, they often don't do it that way and get a real mess, which I can't display to you now without taking another 15, 20 minutes if you want. But now look at how beautiful. What they're going to do now, you're going to be surprised at. He's going to do an everted stapled anastomosis. Now, when you suture it, you're going to think you're a wonderful surgeon, but all this dead tissue will be buried in the lumen, so you can't see it. You'll see this external view, which looks really pretty. You'll see serosa to serosa, and you'll be congratulating yourself, but all that dead staples will be inside in the lumen forever. Okay. So this is an everted stapled anastomosis. Takes only.
For suturing this rent, I mean this gastrojejunostomy rent.
No suturing. Watch, I'll show you. Here it is. This is it. It's done. No suture.
Okay.
See how fast it is? Not for it going fast, but because it's doing better. Look at this. You see this?
Yeah.
Okay, this is a wide open gastrojejunostomy. Remember how wide this was here? And this is all wide open. Plus, all of that tissue that we just saw taken away, you would bury inside with your sutures, and you would be proud of yourself, and I'm proud of you also. But there you have all that dead, buried, stapled tissue in the lumen. Where do you think those staples go? They're buried in there, and then they're bathed in bile and acid and food. Well, this is not a bad, you don't have to do it this way, but this is a good way to do it.
Okay.
Anyways, I talked too much.
No, right. It's a pleasure.
Thank you. Thank you very much, Professor Rutledge. Now I would request Professor Manash to take over, and
I think it's a big pleasure and it's a great honor, Professor Rutledge, to have you with us today evening. And It was a wonderful evening spent and listening right from you, the tips and tricks of doing a good MGB. Thank you, Dr. Rinwald, also joining in. And thank you. And thank you very much, Dr. Kular, for accepting my request and moderating this session in a fantastic way. So thank you, all the attendees, holding on back till the end. We are almost approaching 2 hours. Couldn't know how 2 hours just went by. So that it was fantastic. It was real tricks that you shared with us. We really appreciated it, and we'll be moving forward sometime in future as well. So thank you.
I take this opportunity to introduce Dr. Ilan, my friend from Tijuana, who's visiting, and his team, Stacy and Bill from Tijuana. Happy holidays.
Thank you.
Very often they have to listen to me talk on the phone, and they go, "Oh, please, no more phone calls with Rutledge."
It's always a pleasure, Professor.
Thank you very much, and thank you again. So have a nice and safe stay, and have an absolutely fantastic day forward. Thank you very much.
Thank you. And night, Dr. Jalil. Thank you. Thank you, everybody. Good night.
Thank you, everybody. Good night. Good night.
Good night.